I wanted to go ahead and to welcome today Rachel Arkamot, who is a speech language pathologist. She's an SLP program specialist for Broward County Public Schools. She had previously worked as a speech pathologist at Marjorie Stoneman Douglas High School in Parkland, Florida. And after the mass shooting that had happened there on February 14th, 2018, she started looking into ways that she could help to work with students and other staff how to be able to move forward after trauma. And she found trauma-informed care, and she's been presenting nationally to speech language pathologists and other healthcare providers on how trauma-informed care can be used across a variety of settings. And so I'm going to go ahead and turn over to Rachel and let her move forward from there. But, Rachel, really excited to have you coming and presenting today for the Mailman Center Grand Round. So thank you.
Thank you so much for having me. I'm so excited. Like I was telling the few people that were on before, I'm wearing my Miami sweater. That was my grandpa's. Orange Bowl 1989. So this is my lucky Miami sweater. It's my most prized possession, and it just happens to have Miami. So I wanted to wear it today. I'm going to share my screen. I do want to let you know, I know when I was introduced, some of you may be familiar with Marjorie Stoneman Douglas. I don't talk specifically about what happened there. I don't want you to be worried that I'm going to bring up that. What I do tend to talk about is conversations that I've had after, how I found trauma-informed care, but I don't want you to worry that something might be said that is graphic in any way. So I just wanted you to be aware. Let me try to share my screen. Cool. Okay. So like I said, today I'm going to be presenting on trauma-informed care for providers. And I know there's many of you that are attending today. I don't know what your profession is specifically, but I want this to be able to cover whatever setting you may be in, whatever degree you hold. Trauma-informed care, like I will explain in a little bit, is for everyone. And there's certain ways that can be achieved, and I'm going to go over it in the presentation. I'm just fixing my earbuds because they always fall out of my ear. Okay. So today we're going to talk about what is trauma trauma-informed education care practice, how can we be more trauma-informed as service providers, and then we're going to have time for a Q&A. So please feel free to write stuff down. I think I will have access to the chat. I think I can see the chat, but I have a lot of stuff to cover. So I want to make sure that your questions do have time to be answered at the end. So a little bit about myself. So again, I am a speech program specialist for Broward County. I moved into this position in October 2021. So I still work for the same county that I worked for. I needed a break. I needed a mental break. I burnt out of therapy really fast, and I was an SLP there. So with what happened at the school, I was in my second year as a speech pathologist. I had just finished my clinical fellowship, and that was my first year all on my own as fully credentialed SLP. And I was there for the event that happened. When we came back after 2 weeks, my students were dysregulated. I didn't even know what the word dysregulated meant. I was just thinking, these kids don't feel safe here. How can I make them feel safe? And through research, I found trauma-informed care. And it's been I think last week was the 5-year anniversary. So it's been something I've been educating SLPs and other service providers. I also use trauma-informed care in my personal life. So it shouldn't be just to be used as a service provider. I created the Instagram page PTSD SLP, and there's also a Facebook page, PTSD Resources for SLPs. That's a Facebook group. But the Instagram page was launched to be a place where people can go for information on trauma-informed care, because in the years following, or it took me a year to make that page from what happened to July 2019. I kept getting people forwarded to me that, especially SLPs, that experienced the same thing I did, and they were starting from the bottom of what do I do? How do I support my needs? How do I support students? And I would post stories, resources, and anything like that. So it's become a really great support group in a way. I am a permanent co-host of the Speech Science podcast. I've won some awards with the advocacy work that I do, specifically as a speech pathologist. And one of the best things is I'm a certified animal handler. This is my dog, Dougie, who is obviously named after Marjorie Stoneman Douglas. He is a therapy dog. I went with him for 6 weeks to courses that certified me as his handler. That does not make him a service dog because I have PTSD, which I do have diagnosed PTSD. I also have ADHD. So that makes me neurodivergent. One of them acquired, one of them not. But I don't need him for a service. Therapy work is for the general population. So I can bring him into a nursing home. I can bring him in to work with my students. And he has been trained to do so. But legally, there are no protections. I cannot bring him into an airport, cannot bring him into a restaurant. So this is why we're here today. What is trauma? And there is no consensus in any community that discusses what trauma is. There's no agreed upon definition. So when you research this, you're going to see all these definitions of what considers something to be trauma. And that's where things get really difficult, which I'll explain in a little bit. So here are some things to consider. It is not our job as educators, scholars, or humans to name what counts as trauma for another. And that is one of my go-to recommendations. If you have Instagram, Dr. Dwayne, Addison Dwayne, she's a PhD. She just recently got her PhD, but she researches trauma-informed care and she was a teacher. This is so important because when we are putting people into a box and judging what should be or should not be counted as trauma, that's where we use our personal perspectives and experiences to judge another person. Let's look at what the actual definition is. Trauma overwhelms the ordinary systems of care that give people a sense of control, connection, and meaning. So what does that mean? Like I was saying, we can't say what is trauma for one person or another. Trauma overwhelms a certain person, one individual, the systems of care that give a person a sense of control, connection, and meaning. So when a traumatic event happens, it overwhelms you. This is different than PTSD. PTSD, there are clinical reasons or classifications that need to be met. One of those being that there must be persistent, can't think of the word, but persistent, I guess, issues. I don't want to use the word issues, but it is pervasive in your life for over a month. And PTSD, as someone with PTSD, it's your body is on guard, your mind is on guard at all times. It can't adjust to just normalcy at all. And that's how I experience PTSD. That's not the general definition of PTSD. But trauma itself overwhelms that system and causes your mind and body to go a little bit haywire. Trauma is a pervasive health problem resulting from adversity. So SAMHSA, you're going to hear a lot in the research. This is substance abuse, mental health. They have put out so much of the research on what is trauma-informed care. But the bottom line is that children, adults, we all experience trauma in some way, and it is a pervasive health problem. I'm going to go into a little bit what that means. So why should we, as providers or people, acknowledge that the prevalence and impact of trauma? So research shows the more traumatic events in childhood, the worse the physical health outcomes as an adult. And there was a study that was done in the 1990s. You might have heard about the ACEs study. That's the one that's brought up in pop culture. There had been studies of trauma done before the 1990s, from Black and Indigenous people, from researchers that had done work in those settings. But the ACEs study is the one that pop culture talks about a lot. What that study found was the more adverse childhood experiences in childhood, that significantly reduced the life expectancy. It had more chances of cancer, of heart disease, of all these physical health concerns, and that came from trauma as a child. So it's important for us to note that if you are working with children, they might have experienced trauma. If you're working with adults, they might have experienced trauma. And some of the reasons that you are seeing these patients might have stemmed from childhood trauma, adult trauma. It's also important to consider a possible reason they are seeing you as a provider might be due to traumatic circumstances, or the circumstances that they are there are traumatic in nature. So I think about when you have an acute care hospital and you have, let's say, a neurosurgeon that comes in that just had a stroke. Their baseline might be, their IQ super, super high. The skills that they're able to do is very high. When you give them a Sudoku post stroke, maybe they're able to do that. And if you're comparing them to a patient in the next room who global aphasia, like can't verbalize at all of these things, if you're comparing the two, you're not acknowledging the prevalence and the trauma for that person. So the neurosurgeon might be absolutely devastated that they are only able to do a Sudoku when their baseline is much, much harder. So that's something to consider. The reason that they are seeing you is because something traumatic happened. The loss of independence is hugely traumatizing for many people. So let's move on. So I was talking about ACEs before. The research has really gone to moving away from ACEs because we're putting a number on a certain traumatic event that we feel is traumatic. It does not take into account that someone might feel another event is traumatic to them. So we've moved to more potentially traumatic events. So some of the statistics on that: 61.8% of youth reported at least one PTE before the age of 16. That is very high. We have 674,000 children were affected by some sort of maltreatment in 2017. Many children of color experience race-related discriminatory incidents daily that are physically, psychologically, and social emotionally stressful and or traumatic. We also have research indicates that when a person is subjected to any conditions, situations, or events that produce high levels of stress, trauma is more likely to occur. And I only have less than an hour to talk to you. I could talk to you on trauma for days and days and days. Stress is not necessarily a bad thing. We need stress in our lives to make us do something. I needed stress to create a PowerPoint for you all. I needed stress to motivate me to do things. What happens is toxic stress, or stress that is too high for someone to handle. Population-based estimates suggest that almost 2/3 of children in the US experience at least one traumatic event before age 16. This is a lot to consider. If you are working with children and you have a full class, think of 2/3 of that. That's why my recommendation: you shouldn't be investigating. You should not be a trauma detective. You are not there to investigate what trauma this person, this child has experienced. If you treat everyone as though they might have experienced a traumatic event or acknowledge the prevalence, then you reduce the risk of harm. And that's what we're going to talk about with trauma-informed care. That is the purpose. So, polyvagal theory. The polyvagal theory, this is a theory. So I do want to mention that a lot of trauma-informed care, there is more and more research being done every day, but at the end of the day, it is theory-based. So the polyvagal theory describes the multiple branches of the body's vagus nerve and their role in maintaining our ability to stay safe and to thrive. Our nervous system is continuously evaluating risk in the environment, making judgments, and setting up priorities for behaviors that are adaptive but not cognitive. So I like to use this example, and I was an example I present at FLASHA, the Florida Speech Language Hearing Association, every summer. 2 summers ago, I was presenting in the largest hall, and I was in the green window of tolerance. I was feeling good about my presentation. I was in it. I was comfortable with the content I was presenting. Then all of a sudden, all of the lights went off in the room. All the emergency doors, which was probably 8 of them, slammed shut at the same time, and it was pitch black in the room. And all you could see in this room was the light of my computer shining on my face, and everyone in the audience is looking at me. I can't see their reactions. I don't know how long it took for the lights to come back on. I was told it was 30 seconds maybe. But at this time, since my trauma, it had been a couple years, and I had done a lot of work in therapy, understanding my coping strategies, understanding emotional regulation. I was dysregulated and went to freeze. I shut down. So I'm holding my computer, the light is shining in my face, and I'm trying to assess the situation in my brain. And that is a survival mode. That I'm in survival mode. I'm trying to figure out what's happening. And in that moment, I was like, oh my God, it's happening again. Um, the lights came on. I needed a second, and I'm just looking around the room, assessing that everything is fine. I turned around for a second. I did some deep breathing exercises, and I turned back around and I was like, all right. And I was on this page discussing the polyvagal theory. I turn around, and this was a very small, people had moved to the front of the room to kind of see how I was. So I just started presenting again. And this lady in the front, she was just like, wait, 1 second. How did you just get out of that? How did you go back to green? So I used this chart to show what I needed. So I needed some regulation. I used my coping strategies to get back to a window of tolerance. Once I understood that I was safe, I was okay, I did my strategies, I got back to green. Some people in this situation might have gone to the hyperarousal mode, which is fight or flight. So the reason that I'm bringing this up is I want you to understand that when you are working with patients, clients of any age, they may be in the hypoarousal situation, they might be in hyper arousal, or they might be in the green area, the window of tolerance, which is regulated, and something dysregulates them. So a lot of times, especially as SLPs, we're like, oh, behavior, that's he's choosing to do this behavior. And when I look at students now, I'm like, what caused them? Dysregulation you can consider as a trigger. What triggered them to go into hyperarousal, fight or flight? What caused them to look under hypoarousal? So this is a really important thing to be aware of. So the stress response in kids. And I'm going to talk about kids a little bit, but I want to drive home that this can be used working with adults. This is just how it shows up in kids some of the time. So we have fight, flight, freeze. For fight, that might be yelling and screaming, using mean words, hitting, kicking, biting, throwing, punching, blaming, deflecting, responsibility, defensive, demanding, controlling, oppositional, defiant, and non-compliant. So as SLPs, as PTs, I know there's so many of you in this room that work with students. How many times are kids labeled oppositional or defiant? And what if you just changed your mindset to be like, are they in a trauma response right now? Are they in the fight zone? What is, causing them to act this way? And just that mind shift is taking the blame off the student and having you, again, not investigating what trauma have you been through, but is this behavior caused by something else? We have the flight area. Wanting to escape, run away, unfocused, hard to pay attention, fidgeting, restlessness, hyperactive, preoccupied, busy with everything but the thing, procrastinating, avoidant, and ignores the situation, moving away from what feels threatening. And then we have freeze. Shutting down, mind goes blank, urge to hide, isolates, verbally unresponsive, says, I don't know a lot. Think of how many kids and adults we have that have a little bit of everything here. And again, just acknowledging that trauma might play a part is trauma informed. So I hope when we were looking at that last slide, you might have said, some of this sounds like ADHD. And how many kids do we get on our caseload that are labeled ADHD? A lot of the time, Trauma is the actual area that these behaviors are coming from. So if you look at the overlap, difficulty concentrating and learning in school, easily distracted, often doesn't seem to listen, disorganization, hyperactive, restless, and difficulty sleeping. When so I didn't see a therapist until I think it was a month after everything happened at my school. And I went in and I, talked about what happened. But then I was also like, oh, and by the way, I think I have ADHD. I think, it's been undiagnosed my whole life and I've really struggled and all this stuff. And she was like, listen, we need to focus on trauma first because this is what's presenting and I cannot separate the two. They show up too similarly. So it wasn't until, I don't know, months later when I had been doing a lot better that we went through the ADHD testing and she's like, yep, you have that. But it's also difficult because they show up in a lot of similar ways. So, what is trauma informed care? Trauma informed care is a mindset, not a prescriptive therapy technique. This is one of my favorite quotes. So, along with what I was saying about it being theoretical in nature, there is no book that you can read that says do this, do this, do this, do this. There are a lot of research. There's a lot of research out there now about how systems like an organization can be trauma informed for its providers or just suggestions, but there's no list that is applicable to everyone. So again, trauma informed care is a mindset, not a prescriptive therapy technique. What is trauma informed education, practice, or care? And depending on what setting you're working in, you might, if you're working in a school, education, you might see trainings, trauma informed practice or trauma informed care specifically in the medical settings. And I do want to acknowledge many corporate settings and hospital systems have educated their employees on trauma informed care. My experience as an SLP in education and everything, a lot of SLPs reach out to me currently because we had not been educated on it in undergrad, grad school. A lot of people reach out to me and said they'd never heard of it, which I was in that same boat too. It wasn't until everything happened at the school that I asked myself, what can I do to be a better clinician? How can I make them feel safe? That led me to trauma informed care. But I have friends that are in accounting and they've been educated on trauma informed care or trauma informed practice as part of their CEUs. So it's really interesting that we as a healthcare profession haven't all heard it or haven't been educated on it before. So there are many definitions of trauma informed care and various models for incorporating it across organizations, but a trauma informed approach incorporates three key elements: realizing the prevalence of trauma, recognizing how trauma affects all individuals involved with the program, organization, or system, including its own workforce, and responding by putting this knowledge into practice. Again, SAMHSA, you will see that everywhere. Can we resist re-traumatization with any population? Yes. So when you research trauma-informed care, you're going to see the 4 R's of trauma-informed care. That's realizing, recognizing, responding, and resisting re-traumatization. What happens if trauma-informed care is not in place? I highlighted it for you, re-traumatization. So you all can read this on your own, but re-traumatization is often unintentional. There is no way that we can know what triggers every individual that is in front of us. It is impossible. We don't know their situations, but there are specific things that we can do to reduce the risk of us as providers causing unintentional harm. So the second paragraph talks about specific smells or sounds that can cause individuals to feel re-traumatized. One book that I recommend people read is What Happened to You by Oprah and Dr. Bruce Perry. I think it's a great introduction to the topic. It reads like a conversation between an expert in trauma and a person who has experienced a lot of trauma and talks about it. One of the chapters talks about a child working with an adult and the child would become massively dysregulated in a session. And they tried everything. It ended up being the body spray that the adult wore was the same that the father, who was an alcoholic, used to cover the smell of alcohol on him. So this was something that dysregulated the child without the child understanding that. And as a provider, what can we do once we figure out that trigger? As the provider, I would say, you know what, on those days, I would not wear that body spray anymore. Or just in general, I could change to a different one. But for that student, if I know if he is coming in, I would make sure to adjust that. And there are a ton of other things that we can do in our practice to adjust for an individual. I think of working with autistic clients. A lot of times I'm very sensitive to fluorescent lights. So if I'm in a room, the lights are off, I have a lamp, I have whatever, still so I can see, but I get migraines immediately from fluorescent lights. So we know from autistic people saying that fluorescent lights are a trigger to them, that sensory wise, that's a lot. So when we have a client come in that we know is having a hard time sensory wise with the lights, we can make that change for them. So, pillars of trauma informed care. This is a really important piece that I want to focus on. Depending on what website you go to, there are anywhere from 3 to 12 pillars of trauma informed care. So, I've kind of put them all together into 6: safety, choice, collaboration and mutuality, trust and transparency, empowerment, and cultural, historical, and gender issues. And that would be understanding cultural, historical, and gender issues, or even understanding that you may not be aware of all of the cultural, historical, and gender issues of a patient that is in front of you. So we have safety. All of these pillars I try to implement in my session. So if I have a one-on-one session with a client, I will reflect, and I have an activity in a little bit, on if I have offered all of these pillars in the session. Have I ensured to the best of my ability that they feel physically and emotionally safe? And that is not up for me to decide. That is up for them to decide. And that's a hard thing. If you say, yep, check that off, I'm good with safety, they may not feel the same. So you really have to examine what you're offering. Choice. Individual has choice and control. We as providers, again, I'm going to say that all the time, we develop plans of cares for children, for adults, for whoever, and they need to be involved in that choice and control. There was just a very viral post on one of the Facebook pages that a CF had asked about a patient in a skilled nursing facility that did not want to eat a certain food. And the CF noted that they were vegetarian and was trying to get them to eat eggs. That is not providing choice to that client. Choice would be offering, hey, what else is there that we can have you eat? And yes, it's not a buffet. We hear that all the time, but you need to be respectful. Again, does that apply to cultural, historical, or gender issues? Is the vegetarianism part of their culture? That is something that goes along with choice. Collaboration and mutuality, making decisions with the individual and sharing power. We do not want to put ourselves in a power imbalance just because we have a degree, just because we are the ones providing therapy as an expert. We need to share the power. Trust and transparency, task clarity, consistency, and interpersonal boundaries. The way that I think about this is the patient or client understanding and trustful of where we are going with this therapy? Are we transparent with what the progress looks like and everything? Empowerment, prioritizing empowerment and skill building. That is so important for any of service providers. What is the goal? Is it to, for physical therapy, we want them to be able to reach a certain task? Is it what we want? Is it what they want? What is their goal? And then I mentioned cultural, historical, and gender issues. Again, that would be ensuring cultural, historical, and gender humility. I know has a great program with transgender voice therapy. When you have a selection of people that have experienced um, possible traumatic events throughout their life, we have to be mindful treating them, that we are not causing any undue harm. How can we be more trauma informed? Providers can start using trauma informed lens by self reflection on our emotional regulation skills. This is number one to me, and I'm going to talk about that on the next slide. Altering our language, I'm going to give examples of that. Provide pillars of trauma informed care in sessions with client and families. I just talked about a couple examples on that last page. And then acknowledge that race and racism influence trauma and traumatic experiences. Seek out trainings on trauma, diversity and inclusion, and anti-racism practices, and understand that behavior is communication. So, understanding our triggers and emotional regulation. So I want you to reflect on this, and please feel free to take a picture and use this at any point in your life. I don't necessarily need it to go for your personal life, but I do want you in sessions understand your trigger and emotional regulation. So number one, do you know your triggers? Do you know what makes you upset? Do you know what makes you yell? Do you know what makes you snap? That is what I'm asking. Do you know what you look like when triggered? So again, when you are triggered, do you immediately go to yelling? Do you shut down? What does that look like? Because it absolutely can and will happen in a session. Am I able to identify when I'm triggered? And in the beginning, that might look like after having this presentation, you might go, you know what? I have been triggered before. And everyone has been triggered before. And what I mean by triggered in this instance is dysregulation. Yelling could be that red zone that I was talking about, that fight or flight mode, because that's what is happening. How do you regulate yourself when triggered? Do you just let it ride? Do you let it be angry and just finish being angry whenever that's done? Or do you have any coping strategies to get through that? Is my dysregulation negatively impacting a client? Is my emotional regulation negatively impacting a session? And am I causing harm? That is super important. That's the main idea. We do not want to cause any unintentional harm. Okay. Altering our language. This is something that I'm very passionate about. So removing toxic positivity, some things other people have it worse. After my trauma, we had a ton of toxic positivity phrases that to this day remain very triggering in a way that goes to anger. I get immediately angry and I'm able to control that anger. You're not going to see it, but in my head, I'm raging. Instead, it would be helpful to validate emotion. So when you're working with a 3-year-old that isn't able to go on a slide because it's too big for them, you can say, you know what, those are big emotions you're having, and that is tough, and I'm sure you're sad, all those things. That would have been helpful for me in my situation, instead of saying, with considering what happened, one of the phrases was, they're in a better place. And that really bothered me. Instead of saying that to offer, comfort to me, which many people get comfort from those types of phrases, instead it would have been helpful to say, you know what, this is a really difficult time. I bet you're sad. All things like that, of validating what I'm feeling, validating what your patients are feeling, is more impactful, and research shows that. Toxic positivity can end up being very dismissive of, don't worry about it. Seeking out trainings on trauma, parenting styles, diversity and inclusion, and anti-racism practices. The parenting styles one, I want to make sure I'm not saying how you should parent your children. I'm trying to apply parenting styles to how I can work with clients of whatever age, and that's just how I speak to them. That is the main goal of parenting styles, is how you work with another person. Recognizing our own bias, prioritize teaching children and adults social emotional learning skills as early as possible. So after what happened at my school, we had a lot of adults that could not express how they were feeling. They didn't have coping strategies in place. So we had a bunch of dysregulated adults trying to regulate dysregulated children. And it was a mess. So we need to have those skills in place before something happens, before an emergency, to be able to express it. And um, now we have in our school system, we have social emotional learning that is dedicated a certain amount of time per day for children very early, so that they can understand. And I know it's funny to hear a 2-year-old saying they're frustrated, but that is so beneficial that you can work with them and say, oh, I understand why you're frustrated, or are you angry, or are you sad? There's many things that we can teach. Add inclusive language. So this is in the school system. Parents versus adults. I can't tell you how many first day letters that go out that say dear parents. Well, if you're working at a school that has a high foster population, you can say give to your adults, instead of parents, because that might be a triggering word for them. And I'm not saying triggering as a lot of people think of the word triggering as like a military person that is hiding under a desk, or something like that, that is thrown back into war moments. Triggering is dysregulation, and it that one instance might not be traumatizing, but if you go through your entire schooling career, K through 12, and see parent, 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 you are not being included. That's why I'm asking about that inclusive language. Acknowledging the reason a client is with you may be traumatic. So I talked a little bit about that. And then asking for consent throughout session. As SLPs, we are touching people's faces prompt. I know a lot of people we do feeding therapy. No matter if it's a 2-year-old or an 82-year-old, you can say, I'm going to touch your face now, or is it okay if I touch your face now? Or we're going to be giving you this food. There is a progression to it, and that is part of that respect and trustworthiness. You don't know what trauma people have gone through. That touch is highly triggering. So it is better to just ask as a blanket statement for every single client. Removing violent language. So I talk a little bit about this on, let me go to this one and then I'll go back. Examples of violent language. So considering what you know about the trauma that I've gone through, when I started this new position with the district that my traumatic event happened at work, everyone is aware of what I went through. There are words that I had not heard in 6 years, or phrases. So bullet points. In New Zealand and Australia, they're called dot points. And that's not a big change. Shoot me an email. I hear that every single day. Shoot me an email, shoot me a text. And I heard it yesterday in a meeting, and I was just like, ugh. And I'm not saying that I'm triggered by it, but someone else might be. You can easily say, send me an email. There's no need for all that. When you look at this list, this is just stuff that I've gathered. There are many other violent terms. The term violent language was actually given to me during a presentation. Who an SLP told me their daughter works at a domestic violence shelter. And they are told anyone who is residing there or works there should remove violent language from their vocabulary. And it's such an easy shift. And once you see this list, you're going to be in your personal life or at work, and you're going to be like, oh my God, I didn't realize how often I say these things. Take a stab at it, roll with the punches, target audience. When push comes to shove, take your best shot, execute a plan, and blown away. All these things can be said more directly, without any violence in it. Oh, let me go back to that video. So I love showing TikTok videos or videos in general. I think TikTok is a great platform where people post for advocacy purposes. So this is Deal family. This is their daughter who has, I believe, 2 cochlear implants. And this family talks a lot about having a teenager that is deaf, and certain situations they put themselves in. So when I'm talking about changing language, here's an example of that for this community. What not to say to a deaf person. And I hope you can hear this.
What not to say to a deaf person?
I forgot exactly how to solve these, but I think you just start spinning
Wait,
it a
what'd you
certain
say?
way. Nothing. Just hold on. So like,
What you can do instead?
I can't remember exactly how to solve these, but I think you just spin it a certain way.
Wait, what'd you say?
I'm saying I can't remember exactly how you solve them.
Just face the person and speak clearly. They'll appreciate it.
Okay. So I hope you gathered the point of that, is that the first option that was given was dismissive. It was, too bad you're not going to hear what I said, you missed it. I'm not saying that that one instance causes trauma. But again, over your entire life, for this person, if you are constantly being told, don't worry about it, don't worry about it, don't worry about it, are you a person that feels valued? Are you a person that feels safe? All of those trauma informed care, are you given a choice to participate? No. So this is what I mean, that over the course of time, all these little things add up to possible trauma. Okay. So I'm not sure how many of you have heard of the neurodiversity movement. This is a big thing in the speech field and many other related fields that is run by autistic people. And it's showing us how we can change as providers. One of those things is identity first language versus person first. I think during this presentation, I've been doing a good job of saying identity first, which is what the neurodiversity movement is run by autistic people. And they say, for the most part, they cannot remove their identity from themselves, which is why they prefer autistic person versus what we learned in grad school, which many of you use, and that's the more politically correct way of providers have been educated, is person with autism. Autistic people are saying they prefer identity first. Both are correct. Always ask what the person or caregiver prefers. You might see a difference in the two. You could change IEPs to reflect parents refer to the student with person first language and give an example. You can have those conversations in whatever setting you're working in. Red flags, change to signs. Red flags has a negative connotation. So many parents hear this when they're sitting in their doctor's office with their child who says your child is showing red flags of autism. That is a negative thing. And many parents remember this moment for the rest of their lives. This could either be a helpful conversation or already starting off negative. So it's just as easy to say your child might be showing signs of autism. That's it. Removing ableist language and disability metaphors. So treating autism is not supported much anymore. We don't treat, we don't fix. We help them reach their goals and whatever that might be. I know many of you work with the deaf population. When we use metaphors that talk about disabilities, such as turn a deaf ear to blank, we're not talking about deaf people. We're talking about deafness as a negative thing. So we have to be very careful with using that kind of terminology. Also, high functioning versus low functioning. That's not supported anymore, rather high support versus low support, and name the areas in which they require support. Also, Asperger's is not recommended. You can read more about this online. And the neurodiversity movement is modeled heavily after deaf culture of taking back the narrative that it's not something that's wrong with them. It's just the way it is. And that's something that all providers should be aware of. So when you are educating parents, you need to be aware of any possible belief system. I just sneeze. Okay. So trauma-informed analysis. So this chart, I want you to always take after a session. I want you to ask yourself, was this pillar provided? If so, where? Did you provide safety, choice empowerment, trust, collaboration, cultural, historical, gender issues, critiques? So you can always critique your session of, oh, you know, I could have said this better, or this child was showing an unusual behavior that's not really typical for them. Maybe I should have asked, hey, is anything wrong? I'm not asking you to say, what trauma have you experienced in the last 10 days? Like, that's not what I'm saying at all. It's just being open and aware and opening that conversation of, hey, like, is anything going on? You seem a bit sad today. Like, that's it, just acknowledging the difference in behavior. So something I think about a lot is children's hospitals. We have child life specialists, which I think I want to be a child life specialist. I think that is the coolest thing because they are there to show practitioners and parents what way to reduce harm. So one example that I've heard is when a child is going into surgery, instead of saying put to sleep, because when have children possibly heard that term before, being put to sleep? When one of their animals gets put to sleep. That can create a traumatic experience around sleep itself. So instead of saying put to sleep, there are other recommendations of explaining it a bit more, and I can't remember the phrase that they use, but that is such a trauma-informed view of how can we reduce the trauma if this child is going through surgeries and disease. There are things that we can do to reduce harm. Make sure in your sessions that they try to be as predictable as possible. They're flexible, empowerment, and connectivity. And I know that the systems in place of, I know some SLPs in healthcare and OTs and PTs, they have to reach 90% productivity. Does that encourage trauma-informed care? Absolutely not. It's not providing that individual experience. So as much as you can do as possible, you want to provide empowerment, and you want to promote connectivity between yourself, between the community, whatever you're doing. These are all things to consider, and you can decide how these words fit into your population that you work with. So trauma-informed providers. If you are trauma-informed, you will have greater awareness and understanding of the potential signs of traumatic stress in people around them, have a deeper understanding of how their own past adverse experiences and how they may have impacted their thoughts and interpersonal interactions in life, and gain skills that allow them to thoughtfully respond to trauma in others. One thing that I did not mention, you as a person might have experienced trauma also. You might have experienced trauma through your workplace. I think about constantly just, 2020 for people working in healthcare that had this unknown disease coming around, and how the patient, the explosion in patients at a hospital and providing care was a really difficult time. And a lot of healthcare providers report trauma from that time period and still are kind of going into that trauma. We, based on our jobs, may experience trauma. I think of nurses that have been working for 40 years that have lost their bedside manner just because of compassion fatigue. They've experienced a lot, and many of us have also. There are many providers that work with people who are physically violent. There's stuff that's going on in our personal lives. So that's why I recommend that self-reflection, because there are a lot of things that we've gone through that shape our experiences and judge other people's traumas. You might be a person that says you have not undergone any trauma, and that's exciting. I'm happy about that. But the reality is most people have, and by following these little steps, you can reduce the harm that we could possibly unintentionally cause. And that is the end of my session. And I have left, I think, exactly 10 minutes for a Q&A.
Thank you, Rachel. So what we want to go ahead and do now, if people have questions, you can either, raise hand, you can go ahead and jump in the chat as you prefer. And Rachel, I'll turn back over to you.
Perfect. I saw someone's hand up. If you want to unmute yourself, go ahead.
I have a question.
Yes.
As I was following with your PowerPoint presentation, you mentioned about the triggers of some words, how you can avoid them. It's very hard to just remember to avoid using those words, because they are main words people would actually use. Like, for example, bullet points. What would be a replacement of bullet points?
So I gave suggestions next to them of dot points.
You gave suggestions next?
Yes. So there, you guys should have seen there in black next to it. I gave suggestions of all those things. But I'm not asking you to remember this list and just start replacing those things. It's acknowledgement of those things are triggering, possibly not that they are, but they could be, and just unnecessary in our verbiage. So after I've presented that slide, I've gotten a lot of responses from people who have said, the next day I went to work and I just started acknowledging and hearing that in conversation that I didn't know how pervasive it is. So I'm not asking to go ahead and change your language completely, because it is built into our culture. That's something that we do daily. But just acknowledging and hearing it, you're going to start to hear how often it truly is said. and I can definitely send to the moderators. I'll send that slide to make sure that everyone can see some suggestions of what those things are. And I hope if anyone else wasn't able to see those, but I will definitely send that out.
Okay, you're sending them out to emails?
I'll send them to the moderators, and I'm not sure how they can find how everyone has been in this session, but I will make sure it gets out to the participants.
Okay, I had another, just one last.
Yeah, go ahead.
I know that high functioning versus low functioning is now, it's preferred to high support versus low support. But you said Asperger's is not recommended to use anymore, so they're just under the autism spectrum.
Correct. So
Yeah, I just wanted to double check.
yes, the what has been said about Asperger's in general, Asperger, the person was a Nazi, is from what I'm hearing. So that is the part that they're like, we don't want to support this person who has done the research but participated in this stuff. So that's why they say everything is under the spectrum umbrella in general. So
Right.
it's just an unnecessary term. And it also, from what I've heard autistic people say, is there is a classism kind of situation happening when they say, oh, my child has Asperger's, and you automatically assume that is a high functioning, intelligent, all this stuff.
Right.
So that is a lot of it also, that it's autistic people have said, you know, I might be labeled as high functioning, but in reality, my social skills are adaptive, but my coping strategies are very low. So what part of me is high functioning? It's more about what areas need support. And it's more of descriptive terms for us. But these are just suggestions of what the neurodiversity movement has outlined.
Okay, thank you so much.
You're welcome. Anyone else? And please feel free. I know I put my email address, and I'll type it in the chat as well. If you want to talk about anything, I'd be happy to, jump on a Zoom call with you, go over anything like that. I see a few familiar names on this Zoom, so I'm happy to see your names again. And yeah, I'm always happy to talk about this. I can talk about it for days.
And I think it looks like Camille has a question,
Yeah,
and
go
I
ahead,
see hand
Camille.
raised.
Hi, yeah, quick question.
Yes.
So, you're talking a little bit about person first versus like the other first. I'm sorry, I forgot what it is. Would you say that that's only for individual, like for neurodivergent individuals, or would you say that that also applies to, like, let's say like people that have been diagnosed with like anxiety disorders or like depressive disorders or anything like that? Because like I went to grad school, it feels like a million years ago, and so we weren't we learned to like not, let's say, talk about clients like, oh, this depressive person is whatever, it's just the person with depression. But like it seems like maybe with like with neurodivergency, it's sort of like a different category. It's not like you mentioned, it's like part of the person. It's not really something that's like goes away after a certain period of time.
I don't know if there's a blanket way to think of it. I think that the main thing that we need to do is ask how people like to be referred, because there are people within the autistic community that disagree heavily with the neurodiversity movement. So it's just being aware that you might have a parent that's coming to you that says, oh no, I prefer identity first language, or you have a parent that's coming to you and say, please use person first. You are going to have multiple views of that. And I know that when I said that the neurodiversity movement has been modeled after the deaf community in a lot of ways, you don't say, I'm a person with a person with deafness. It's, I am a deaf person, and that is part of the culture. So that is, again, how this has been modeled, but I don't think that there can be a blanket statement. My suggestion is just to ask how people like to be referred. You're welcome, Camille. Anyone else?
Hi, Rachel. This is Christina. I'm an SLP as well, and I want to say thank you for sharing this presentation with us. As you said in your presentation, we don't get that training. We don't even get training on counseling or how to deliver diagnostic or unexpected type of news. And when this presentation was first brought to our attention, I was like, wow, this really does fall within our scope. And as the communication, quote unquote experts, I think it's important that this is brought into, our realm. I lean heavily on my psychology colleagues, and they've done so well in teaching me, but it's nice to know that SLPs are being trained in this area as well. So thank you for that.
Thank you so much, Christina. And this is a hot topic in the speech field specifically, and I'm not sure what everyone here, how much of you are SLPs, but last night there was a town hall by ASHA that was an hour and a half, and it is becoming something that is talked about a lot, and I hope that it's not a fad, that it goes away very easily, but this is something that has been asked for specifically after COVID, that they're like, we are experiencing people with such trauma from the last few years. How do we work with them? So I think it's a little bit delayed that we're getting this information out there. I'm speaking at ASHA Connect, which is a school-based conference in California this summer, and I have been reached out to by grad students. Those are the ones that are saying, can you please present to my professors?
Right.
The professors are saying, please present to my students. And I'm actually reading therapy books. I'm reading books on how to be a therapist, of how do I talk like with active listening. So
right.
Although we are not therapists, we're not trying to get to the bottom, we're not psychiatrists, psychologists, we can still use skills that therapists use to speak to our clients. That is the main message of this. So I am presenting more about that, and there will be more about trauma-informed care in our field.
Yeah, and especially with the fact that we counsel parents too. I think this is something, it's like we're working with the child, but we're also working with the parents. So it really comes full circle in that sense.
Yes, thank you so much, Christina. That's very true.
Renee, did you have a question in?
Hi, everyone. So, well done, Rachel. Awesome job. As I kind of mentioned it in the comics, I mean in the comments listed, but yeah, I've noticed I'm an SLP as well. I work for Early Steps, and I came from Miami-Dade County Public Schools, and I recently was asked to present at FLASHA in the panel for the diversity, inclusion, and equality, and I know that they're making a massive push for that. So this kind of goes hand in hand with it. So well done. Just kind of putting it out there. I know that kind of saying kind of like what Christina was saying, that in graduate school, they really don't discuss this. I know that in one of my clinical rotations, when I was at one of my private autism placements, I remember my professor or my supervisor telling me just to be mindful, and kind of with children that fall under ASD, just see what we can do, that what changes we can do, because most of the time they're reacting and we're not aware of how we're acting. So it's something that we can do ourselves to change certain behaviors. So it's just those little things that, I mean, at school, they never taught us that. That was something that it was a quick conversation that I remember that I got it. And because I was actively listening, like what you're saying, it was like, oh, picked up on it. So well done.
Thank you. I appreciate your comments for sure. And I'm happy to see you on the panel. That's FLASHA is doing a great job, and I've presented for them for the past 4 years. That's the same weekend as ASHA Connect, so this is the first year that I won't be attending and presenting, but it's such an area. I've been told each year at FLASHA, I made it very clear at this past one that I present on trauma-informed care across all settings, because many people told me they didn't go to my session because they thought it was a school-based issue. And I said, at what point in this title makes you think that it's school-based? Or they thought it was TBI related. They thought trauma was related to brain injury. So I wanted to make it very clear this can be used by SLPs, by OTs, PTs, audiologists, whoever you are. This applies to everyone.
Well, thank you so much, Rachel, for coming and presenting for the Grand Rounds today. I think as everyone, you should see in the chat, is the link to complete the survey and give us your feedback on today's presentation. And thank you everyone so much for coming. And thank you so much, Rachel, for presenting
Thank
today.
you. I appreciate you all.